All right, I believe we are live. And I don't know how many times I said this, right? I believe we are live. So good afternoon. Today is October 8th, 2021. It's our Bariatric Friday with American Surgery Center and CHRIAS. I have Dr. Isaias Irgau with me, and my name is Kemal Erkan, but many people already, those who are following us, they already know who we are. But as always, I'm going to ask Dr. Irgau to introduce himself and start with him, and we'll open our topic for today.
Thank you, Kemal. Hello, everybody. Welcome to Bariatric Friday. My name is Dr. Irgau. I am a bariatric or weight loss surgeon. I have been performing weight loss surgery now for 20 years, and with my associates at CHRIAS, we are by far the most experienced surgical group when it comes to bariatric surgery in our area.
All right, thank you, Dr. Erkan. And those messages we are getting is from our distribution group, so I apologize for
no problem
making the sound there. So, all right, so we are going to go ahead and start, and I do want to introduce our other surgeons in the program who are part of CHRIAS and Surgery Center. So this is our weekly event. And then from our team, Dr. Irgau, you guys already know who he is. And we have Dr. Gail Wynn. Dr. Gail Wynn is one of the most experienced female surgeons in the United States in bariatric and probably in general surgery as well. And Dr. Mike Peters, Dr. Rahul Singh, Dr. George Ibrahim. These surgeons are from our bariatric team. And also we do have a colorectal surgeon, Dr. Sachin Vaid, who's been with us for a long time. And we are one big team in Delaware. But we also have our dietitians who are working with our patients very closely, those individuals, that friend Amy and Beth. They work with us very closely with our patients throughout the process. From those who may just be watching this first time, is CHRIAS is the most experienced bariatric program, most likely in the United States. Over 10,000 surgeries amongst five of our bariatric surgeons. And last 3 years, actually, it's about 2,000 and maybe more surgeries that we are doing. That's pretty much like what we do every day, meaning that how you get better and how you do better in a clinical setting is doing the same thing for years over years, but also adopting the new technology and adapting the new stuff, but building on what you already established prior. So, Dr. Irgau, we want to discuss the multivitamin use after bariatric surgery, the reason for that, and what our patients should be doing after the surgery. Most of them are way too happy after they lose so much weight, and sometimes they don't follow up with us because they are doing so well. But then we want to make sure that this is a life-changing event, and we want to support them for their entire life. So if you can actually give us the background of the surgery first with the qualifications, and then we'll get to the multivitamin use after the surgery.
Absolutely, Kemal. Thank you. This is actually an extremely important topic. It's very important for us as bariatric surgeons because when we do bariatric surgery, we bring about changes in the digestive tract that in one way or another interfere with the intake of vitamins of our patients. So what their vitamin status is after surgery is an extremely important part of the follow-up that we do with our patients. The two main procedures that we undertake right now, the sleeve gastrectomy and the gastric bypass, and to a lesser extent, the duodenal switch, are all procedures that lead to some interference with the ability of our digestive tract to take nutrients, but also vitamins. Vitamins, as you know, are those micronutrients that our body needs in small amounts, but absolutely essential for our health and for our existence in some way.
In terms
Clearly,
of the actual qualification of the surgery, Dr. Irgau, just if you can just summarize the baseline qualification, that would be a good start.
Absolutely. In terms for bariatric surgery, you mean?
Yeah.
Yes, absolutely. So bariatric surgery is a very effective treatment, probably the most effective treatment that we currently have for morbid obesity. Morbid obesity is defined as obesity that has gone really completely out of control. And there is a fairly clear definition in terms of how much weight will a person will have to be overweight by, for them to be classified as morbidly obese. And that's about 100 pounds over their ideal body weight. So if a person's ideal or healthy weight is about 150 pounds, and yet today they weigh 250 pounds, that means that they are identified as morbidly obese from that classification point of view. Another way to look at this is to talk about body mass index, which is a number that is calculated by taking the height and the weight of the person together. And the body mass index that defines morbid obesity is 40. Now, to this definition, as you know, there are exceptions. Sometimes excess weight less than 100 pounds or a body mass index less than 40 can still make a person qualify for weight loss surgery if they have developed some very serious illnesses related to obesity, like type 2 diabetes, like high blood pressure, or like sleep apnea. So the definition
of the screening after they start their consult with us. So then, if those illnesses are already diagnosed by their primary care physician, that's we would start the process. But if they didn't know, like in many cases, as you know, when we go through our daily case conference, we look at the blood work, and in some cases they don't have any recent blood work, and usually from our surgeons they are ordering the blood work, and some patients are finding out that they have diabetes.
Absolutely.
From that
Absolutely.
process.
Absolutely. This is actually a fairly common occurrence. You will have a patient coming to us seeking bariatric surgery, and then we look at their body mass index, and it's not 40, maybe it's 37, it's 38, which is below that 40 level. And then on the surface, as you say, they don't have any major medical illnesses related to obesity. But when we do blood work, like for instance, when we do A1C, which is an indicator of diabetes, to the patient's surprise, we find that it's elevated and give them a diagnosis of diabetes. Or sometimes we ask patients some very important and probing questions that tell us that that patient may actually have sleep apnea, which is a very serious problem, very closely related to obesity. And then even though the patient may on the surface not look as if they qualify for bariatric surgery, when we send them to do a sleep study, then we confirm a diagnosis of sleep apnea, and then they would become candidates for weight loss surgery.
Dr. Irgau, with the comorbidities, and you don't like it when I call comorbidity because you want me to be more specific to the illness. So these other illnesses that patients may have, as you know, like you are also the vice chair of our ACO, and we work our case conferences right after bariatric one. I spent another hour with our ACO nurses. One of the things that we discussed in our earlier session today is how these chronic illnesses are correlated. And interesting enough, when the A1C is not being managed, those patients are highly to have depression.
Yes.
And like when you have the data in front of you, and you always look for the patient with the uncontrolled diabetes, the next thing you see is the depression. And then I thought I was the first one to find this problem. Apparently it was already known, but many people may not know. Now, when we look at our program, from our program standpoint and our main focus of the obesity, morbid obesity has this friendship with so many different illnesses, and many people don't even know what actually is the problem. So in the diabetes example, for example, in that when the diabetes is controlled, then the depression is controlled. But in our setting, if the obesity is controlled, it has positive impact for all the other issues, problems, illnesses that patient has. So that actually is something that we want to kind of talk a little bit more in our next sessions. And I think for people to understand that this is not just an isolated problem that you are just having this surgery to get rid of the obesity. It's not. So it's the life-changing event, which actually increases the life expectancy and all that. But I think there are some issues. People still have questions. Like even if you have the best outcome, there is the vitamin deficiency issue. And if we can kind of go back to our topic for today, what our patients should be doing after the bariatric surgery in terms of vitamins.
Absolutely. So in terms of the vitamins, clearly as a baseline, even if somebody has not had bariatric surgery, just by living in our modern society where access to fresh foods is limited, we will be lacking vitamins. So it's essential that most of us actually do take multivitamins even before bariatric surgery. So if you do blood work on somebody who's not even a weight loss patient, and you look at micronutrients, you look at their vitamin levels, very often you will find that those vitamin levels are actually lacking. So, you start with that baseline and you undertake bariatric surgery, right? And bariatric surgery, whether it's the sleeve gastrectomy with the removal of a portion of the stomach where the digestion starts, or gastric bypass, where there is not only disconnection of the upper and lower portion of the stomach, but there is rerouting of the intestine in such a way that that early and very active portion of the intestine is taken away from the path of the food, from the path of the nutrition, which means that whatever nutrients there are within the food that the person eats, some of them may not be absorbed properly, and that includes the vitamins. So our patients, by really having the surgery, are going to be at risk for vitamin deficiency. So it's very critically important for our patients to follow our instructions about intake of vitamins, but also to follow with us on a regular basis so we can do blood work to see if they are deficient of a specific type of vitamin as we go ahead. Now, this question of being deficient of vitamins after bariatric surgery is much more pronounced with the procedures where there is rerouting of the intestine, like gastric bypass, like the duodenal switch. But it can occur with the sleeve gastrectomy as well. So from all our patients' point of view, we emphasize this.
And I think it's the fact that even if you don't have the surgery, these vitamin deficiencies are like they're already there.
Absolutely.
And people are not paying attention.
Absolutely, absolutely. Some people may be surprised that vitamin deficiency can occur even with the sleeve gastrectomy, where we really are removing a portion of the stomach, which is that part of the digestive tract that really doesn't absorb anything in terms of nutrients. But people need to understand that the digestive process starts way earlier than the intestine. In fact, it starts in our mouth with our saliva. That's where digestion starts. And then it proceeds in the stomach as well. And in the stomach particularly, there are some important things that happen to vitamin B12, for instance, some things that can happen to the type of iron that we have in our food. So by interfering with the integrity of the stomach, which is what we do with the sleeve gastrectomy, we will be interfering with the person's ability to process properly micronutrients like iron and B12, essentially. So all our procedures, as I said, whether it's the sleeve gastrectomy or to a greater extent, obviously, the gastric bypass and the duodenal switch will lead to some type of vitamin deficiency. Now, this should not be a reason for people not to seek bariatric surgery. On the contrary, remember, when we look at the benefits of bariatric surgery, the benefits by far outweigh any type of drawbacks that there could be with the surgery. But the drawback of not being able to absorb vitamins actually is something that we can fix very easily. First of all, with education for people to understand. Secondly, by providing multivitamins that people should be taking afterwards, but also importantly, by doing blood work afterwards. For instance, one of the vitamin deficiencies that we identify very commonly, particularly in our female population, is vitamin D. Vitamin D, in fact, if we were to look at our data, Kemal, we do vitamin D check on all the patients that come for bariatric surgery in our practice. I wouldn't be surprised if 60 to 70% of them will have some deficiency of vitamin D, right? So we look at that and we start with some treatment of high doses of vitamin D that is given on a weekly basis, 50,000 units taken on a weekly basis for up to 12 weeks. And then we don't stop there. We recheck the level again to make sure that no additional treatment is necessary. So in summary, really, vitamin deficiency can and will occur after bariatric surgery, whether it's sleeve gastrectomy, gastric bypass, or duodenal switch. And it is very important for post-bariatric patients to be adherent to their intake of vitamins, whether it's just multivitamins or multivitamins and added vitamins like B12, folate, vitamin D that we will be prescribing for them.
Now, Dr. Do you take daily vitamins?
I do take multivitamins.
Did you have bariatric surgery?
I did not have bariatric surgery, but I do take multivitamins. And the main reason, again, Kemal, is that multivitamins are very, very present in nature, right? In the foods that we eat. However, they are present only when you have the food source really fresh, right? So if you were taking your food from your garden, for instance, by getting the plants from there and eating it, the chances of you having the macronutrients would be high. But how many of us live that way, Kemal? How many of us have a garden in their backyard where they depend on it for their subsistence? Very few. I don't know anybody in America that does that, right? There are parts of the world where people live there. And in fact, in those parts of the world, multivitamin intake may not be heard of or common. But in our society in America right now, the food that we eat, we get it from the store, and the store got it from another supplier, and the supplier got it from another supplier. So the food has been away from its source, from its fresh source for a long time before it gets to our table. And in that process, there will have been loss of those essential nutrients like the multivitamins. That's why it's important for us to be on multivitamins, but more importantly, our patients, our bariatric patients, because of the interference of the surgery itself with the capacity of our digestive tract to absorb vitamins, it's important that they know this and that they follow up with us on a regular basis for us to do blood work to check on any deficiencies.
You see, Dr. I think the part of the maybe issue that I always hear how we are actually making these relations between it almost sounds like if this problem is only for patients with morbid obesity. Well, that's one of the things that we've been saying, even like with the watching our diet, like you don't have to have morbid obesity to do what needs to be done day to day. Like you and I, we've been diet partners for a long time. I think you do a better job than I do, but we are not even close to the level of the morbid obesity from any point, but we have to keep it active and we have to put a lot of effort. And on this one, like I see the same issue. Like if many people they just tie this into the more like the surgery, but it's not. These patients do have these problems already. Now it becomes more important to take care of them because of the changes that they are going through. So this is just to support for that person who actually should be taking those vitamins, even if they didn't have bariatric surgery. That's part that I do want to kind of emphasize, and I do that over and over again. But we always want to believe in what we want to hear, so then it's difficult to just explain these. And in earlier session, we did have. We did analyze one of the articles, the Bill Gates video, and it was interesting how people want to just interpret these things in a different way. And he says one thing, but people understand very differently. And it's amazing. And that's why I want to make sure that we keep that separate from just the morbid obesity. This is not something that is because of the morbid obesity, but because of the procedure that they go through. They need a better support because now they have a new life. They lost so much weight and they need to eat better. They need to, just like with our patients with diabetes, we have to, in some cases, we teach them what to eat. Because even if you have the fresh food every time, like the balance between what you eat with the protein, carbs, and the others, so there has to be that kind of learning process. And that's what we've been doing now. I think just to explain for our patients what type of support that's available after the surgery, that would be also important.
Absolutely. So clearly, bariatric surgery does not stop, at least in programs like ours, who exceed in excellence, right, in terms of the quality of care that we provide. Bariatric surgery does not stop with the consultation and the surgery itself. Bariatric surgery actually leads to a relationship between us and the patient that should be a lifelong relationship, right? And that's the reason for that is multifaceted. One of the reasons we already explained, because it's important for us to be able to follow up our patients in the long term to make sure that they don't become deficient in some of the nutrients because of bariatric surgery. Another reason is because of what you were just saying, Kemal, right? What you were saying really essentially the fact that all of us are in the midst of this struggle to try to curb weight suggests that we live in an environment which is continuously enticing us to fail, right? Because of the type of food that are pervasive around us, because of the lifestyle that is so imprinted in how we live, right? With little activity, little movement, right? So because we do bariatric surgery and we don't change where these patients live, we put them back in the society that they came from, right? We put them back in the structure that they came to us with, right? Which is filled with potential reasons for them to fail again, whether it is not losing enough weight or because they struggle with weight regain. So following our patients to support them in these struggles is very important. Yes, we tell them that bariatric surgery is not a magic answer. Yes, we educate them that bariatric surgery is a powerful tool and it requires a fundamental change in the way they live for it to be successful in the long term. But we know also that they are human beings. All of us can at some point struggle, no matter how much willpower we have and no matter how strong we are, right? And in that setting, it's critical for us to be there to support our patients. And I really emphasize this point greatly for our patients because the tendency is very often, Kemal, for patients to follow up really to show us that they're doing well. But then when they find themselves struggling, somehow they feel as if we're going to be disappointed and they don't come to see us. But that is precisely the time they need to come to us so that we can provide support. And what does that support look like? Well, first of all, we sit down and listen to understand what the struggles are, whether it's stress, whether it's snacking, whether it's lack of access to certain foods, whether it's an inability to exercise. All those things are important. And we can provide counseling. And this counseling sometimes can be frequent. I have patients that I ask to come and see me every 2 weeks at some point until I get them back on a good track, right? And we have our nutritionists, right? The wonderful nutritionists that you introduced at the beginning, they are there also to support our patients afterwards. So this relationship with us, again, does not end with the surgery. In fact, far from it, it begins right with the surgery. And then in the long term, we want them to follow up with us so that they become successful for the rest of their life.
Dr. Irgau, one of the questions that we have from the live chat is there information about the best multivitamins?
So I actually don't think there is any special one, Kemal. By far, almost all multivitamins that are approved to be on the market right now will have pretty much the type of multivitamins that our patients will need. So yes, we do have some that are specifically constituted for bariatric patients, and we have them in our office as well. And the advantage in those may be the fact that they may not be needed to be taken, multiple times a day, and certain vitamins that are specifically lacking after bariatric surgery, like gastric bypass, may be in higher doses in those vitamins. So yes, those specific bariatric multivitamins could be important for our patients. But at the end of the day, I want to ask our patients to really, really take what they can take, right? So I don't want inability to purchase a certain vitamin, inability to find a certain brand to be an obstacle by itself, right? The number one basic thing is to understand they need multivitamins. If they can start with that, then we can check. We can see, okay, is your B12 low on the test that we've done? Is your vitamin D low? Is your folate low, right? If we find that those are low, we will add additional vitamins to make sure we make up for that.
So it's really like they do have enough to probably do the work like these vitamins. So it's not necessarily brand is as important. It has to be the right ones, and we have to take it in the right time. And we also have to watch what we are eating. So this way, we are not actually really promoting one brand over another.
But in that respect, let me perhaps add something, Kemal. There is tolerance of the actual formulation, right? So there are some vitamins that are chewable, for instance. There are some vitamins that come in a liquid form. There are some vitamins that come in a pill form. There are some vitamins that come in tablet forms, right? So all those, they are fine. We want the one that the patient is able to tolerate. Now, there was a time, Kemal, in the past when we insisted that our patients avoid pills, right? We didn't want them to take pills. We want them to either crush them or find a liquid form or find a chewable form. Well, in time, we've actually learned that it is okay for patients to take pills, right? They can. Now, there may be certain pills that are very, tablets particularly, that are so big that swallowing them, they may have a hard time. Yes, they can break them and then take them in that fashion, or they can find a chewable type that may be more amenable to them. So this, again, which one we recommend in this respect is going to be based on which one is most likely the patient to be compliant with, right? So you want to increase compliance, and then that has to take priority.
So the main thing is, even for those patients who may not go through the procedure, before they actually decide what they need to do, they have to work with their primary care physician and then see what their blood work tells them, and then just make the decision based on that. I think that is one of the, again, questions that I'm just looking at the chat box, and that was one of the questions that we have. So the blood work probably would be the key to decide. But for our patient, there's a specific setup that we want them to follow. Now, I'm going to go back to the support after the surgery. So we have this NISQIP, which is the national standards for surgeries, and that's for the Bariatric Center of Excellence. We have to report back to the society, like to the Bariatric Society, what our outcome is and how we are following up on our patients. And many people don't understand that these certifications, these accreditations are difficult to achieve because they are actually being measured, not only measured for us, but they are being compared with the others. So, and they are public at that point. So we actually have a really good program that actually allows patients to stay in the system for at least 5 years, which follows the Bariatric Center of Excellence standards. So, but on top of that, our dietitians, they are working only for our program and are as part of our ACO. So they are not part-timers where they just come for as needed. So they are part of our staff, which Dr. Irgau and I, we believe in permanent staffing. I'm not saying full-time, but I'm saying permanent staffing, that they are part of the program organically, not necessarily they are coming in and out. So this is the same thing that we see with our nurses as well as with our dietitians. So regardless of what we have, they are always there to support our patients. Now, I think one of the the silver lining of the pandemic that we went through is the telemedicine, and many patients, they were not able to take time off from their work because if they have a 30-minute appointment with the nutritionist or with the surgeon, they have to take at least 1/2 day off, which was making it more impossible. But now they are able to actually have telemedicine, and this increase our compliance rate with our patients, and we are more accessible to them. So hopefully this would really help them to understand the process. So now, as always, I kind of brag about our what's really important for us is our patient survey results. So last 13 months with 165 total surveys that came back, we are at 99.4%. So Dr. Guy, like three more months will be 100%. So this one will be off here. So I know that we are putting a lot of effort into this. Now, from our patient surveys, one of the really nice things that we said before, how much time they take to put different comments, not just saying that they are satisfied, but they're also putting a lot of good comments for us, and we appreciate those. And our goal is to make sure that our patients are happy. So Dr. Irgau, from the multivitamin side, I don't know if you missed anything that you wanted to add.
No, I think you mentioned it. I would like to tie it up to this last issue that you raised about telemedicine, though. What a wonderful platform, for instance, for this multivitamin follow-up, right? You don't need to have that physical interaction for a person to lose 3-4 hours to come to the office to discuss the vitamin issue. We can discuss it on telehealth without any problem, right? We can talk about their blood results. We can talk about ways to increase their vitamin intake. We can talk about what type of vitamins can increase this. This is perfectly set up for telemedicine. So the arrival of telemedicine is going to help us greatly, really, in our relationship with our patients and in the quality of the care that we provide.
And I don't know if maybe like when we are doing the live event, sometimes I may not be able to hear everything that you are saying, not because I don't hear you, but I may not be following. The one thing is, did we mention the support group with the multivitamin that actually after the surgery, part of the other support that we have is also the bariatric support group that we do once a month. That also helps patients to exchange ideas and see what works for them and what doesn't. And that's another way of satisfying those questions that they may have. Speaking of those events, we are now back on the schedule with 3 p.m. on our Bariatric Fridays. So by this time, Dr. Irgau finishes a couple of surgeries, and then he's back to these events. And then we have our weight loss seminars, second and fourth Tuesday, and then UMACR updates 2 p.m. every Friday, and then Wednesday wellness webinar, which is focused on the diabetes part of it more. It's second and fourth Wednesday at 7 p.m. And then these are all live events that we have for our patients. Well, Dr. Irgau, thank you so much for joining me today. This was, as usual, this was a lot of fun. And hopefully our patients are also finding these beneficial. And we'll see you soon then. Thank you so much for joining us. Bye-bye.
Thank you. Thank you. Have a good weekend.